Hello, this is Cameron Sabat from Cutting to the Case, and I'm here today with Dr. Robert Pearl, MD. Dr. Pearl served as CEO of the Permanente Medical Group and co-CEO for Kaiser Permanente for 18 years. During his tenure, he led 22,000 physicians and 103,000 staff, overseeing the nationally acclaimed care of more than 10 million Kaiser Permanente members on the East and West Coasts. Named one of modern healthcare's 50 most influential physician leaders, Pearl is an advocate for the power of integrated, prepaid, technologically advanced, and physician-led healthcare delivery. More than 80,000 readers subscribe to his newsletters on healthcare, including his widely read monthly musings on American healthcare. Dr. Pearl is a clinical professor of plastic surgery at Stanford University School of Medicine and a faculty member of the Stanford Graduate School of Business, where he teaches courses on strategy and leadership and lectures on information technology and healthcare policy. His latest book, ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine, debuted as an Amazon top new release and bestseller in 2024, with all profits benefiting Doctors Without Borders. He's also the author of Mistreated, Why We Think We're Getting Good Healthcare and Why We're Usually Wrong, a Washington Post bestseller that provides a roadmap for transforming American healthcare, as well as Uncaring, How the Culture of Medicine Kills Doctors and Patients, which earned the prestigious Kirkus Star. Dr. Pearl is also a Forbes healthcare contributor and a top voice on LinkedIn, where he publishes the popular newsletter Breaking the Rules of Healthcare, which I myself have read as well. He hosts two podcasts, Fixing Healthcare and Medicine the Truth, with over 200,000 listeners, and routinely appears in the top 10 rankings for health podcasts. As a healthcare and technology expert, Pearl has been featured on CBS This Morning, C-SPAN, MSNBC, NPR, and in Time, AP, USA Today, and Bloomberg News. He's published over 100 articles in medical journals and contributed to numerous books. Dr. Pearl is also certified in plastic and reconstructive surgery. On top of all of this, Dr. Pearl received his medical degree from the Yale University School of Medicine, followed by a residency at Stanford. From 2012 to 2017, he served as chairman of the Council of Accountable Physician Practices, which includes the nation's largest and best multi-specialty medical groups, and participated in the bipartisan Congressional Task Force on Delivery System Reform and Health IT in Washington, D.C. Introducing Dr. Robert Pearl.
It's a pleasure to be here today. I look forward to our conversation.
Thank you so much for joining us today. This is really an incredible opportunity. And, as someone who's interested in surgery myself, and a lot of the audience here as well is too, the nexus of surgery and policy and technology, and you really have served at the crossroads of all of this. So you led at the highest level Kaiser Permanente for nearly 2 decades. What do you see as the single most transformative leadership decision you made during that time?
In terms of the most transformative leadership decision, it began very early when I was first selected. I was chosen because Kaiser Permanente was in trouble. It had lost money for 2 consecutive years. It was down to 2 days of cash. We had to borrow a day of cash just to meet the state regulatory requirements. And I made a decision that our future would be dependent upon shifting our strategy. It was at a time when there were all these new for-profit HMOs coming into the marketplace, and they were willing essentially to make it difficult for patients to get good care in order to lower their costs and increase their profits. And we would not do that in Kaiser Permanente. But our traditional strategy of just trying to compete on price could no longer work in this cutthroat marketplace. And so the strategy that I embraced was quality and service differentiation at a competitive price. For I saw that because we were integrated, because we were prepaid, capitated, because we were now embarking on the newest technology of the time, that we could help patients achieve better outcomes, get easier access, and do so at a competitive price. Not necessarily much lower, a little bit lower, but not a lot lower as we had in the past. And as a result of that, we became number one in the nation out of 1,000 programs in quality based upon the NCQA. We were providing 70% of patients with routine problems, same day, next day access, something that the community could not do. We improved our clinician satisfaction, so it was 20% above doctors in the surrounding community. We did all of that with, I'll say, about a 10% lower price. And as a result, we grew our market share from 34% to 47%.
Yes, absolutely. And that's really incredible just approaching it from the business side of things to understand in a competitive marketplace, how do you differentiate yourself when so many other products can be cost effective as well? How has your perspective in that case on integrated prepaid physician-led care evolved since leaving the CEO role? Has it?
Well, it's evolved in the sense that it's gotten incredibly more intense because when I look at the current American healthcare system, it's completely failing.
Mhm.
I mean, we have half of Americans who can't afford to pay their out-of-pocket expenditures should they become sick. We have 400,000 people who die every year from misdiagnoses, another quarter of a million from preventable medical errors. We have almost a half million people who die from heart attacks and strokes and kidney failures and cancer, that if we better controlled chronic disease, that we would not encounter, or at least encounter far less often. No, when I look at it, what I really believe right now is that the fundamental problem is the pay for volume, the fee for service methodology that we have for simply drives more volume, more cost. There's nothing in it that ties into keeping people healthy. According to the CDC, if we could achieve chronic disease management as well as the best programs in the nation, like a Kaiser Permanente, then we could reduce heart attacks, strokes, cancers, and kidney failures 30 to 50%. Now, think about what that would mean for our nation. But as long as we have fee for service in there, we're not going to do it. And so we need to make that adjustment. So I say, if anything, the evolution in the healthcare world, one towards gaining market control for monopolization and raising prices, one towards finding ways to be able to acquire doctor practices and raise the dollars that it charge, the entry of private equity. We could have an entire list of challenges that have only become worse, more difficult for our country. And what we've seen is that life expectancy has been stagnant. It's no better than 2010. Think about that. For 15 years, we haven't gotten any better. It's hard to imagine that that could occur, but we haven't, I don't think we've tried. Now, don't get me wrong. Doctors work incredibly hard. They're very dedicated. I'm not talking about the people providing the care. They're the victims. I'm talking about the people, the hospital administrators or the hospital boards of administrators. We're talking about drug companies. We're talking about private equity, some insurers. We're talking about a lot of individuals for whom the current system works just great. But as you well know, particularly around burnout, it's not working very well for the providers of care. And I have great empathy for them.
Yes, yes. And it's really incredible to see you bridging those two worlds in your career. So I also, had a question about the role of AI. Your new book, ChatGPT MD, argues AI can empower both patients and doctors. What excites you most about AI's role in healthcare, and what keeps you curious or
Oh,
cautious?
yeah. Generative AI will be the game changer. It has the potential to be if we embrace it. And, as you say, I wrote two previous books, and in both books, I could point problems, but I really didn't have a solution that I could give to the clinicians. Because when I talk about capitation, I don't mean at the insurance company level like today.
Mhm.
I mean giving it to the doctors and to the hospitals that work with the doctors to be able to provide care in more efficient and effective ways. When I look at chronic disease, the basic problem is that our fee for service, our pay for volume methodology might have worked 50 years ago when doctors took care of pneumonia and they took care of a broken bone and maybe appendicitis. It doesn't work when we're talking about chronic disease. Someone walks into a physician's office with high blood pressure, or someone walks into the clinician's office with diabetes. They're going to need 4 visits a year for the next 30 years, 40 years, we're talking about hundreds of visits that are going to be required over their lifetime. And doctors just don't have the time.
Mhm.
So what we need to do is to figure out how can we empower patients. That's the subtitle of the book, how AI empowered patients and doctors can take back control of American medicine. It's this notion that we do a poor job monitoring chronic disease. Why is that? Because doctors are too busy.
Mhm.
You give someone a wearable device, a blood pressure cuff, they can measure their blood pressure 3 times a day for an entire month. At the end of the month, they have 100 readings. They can determine after 1 month of new medication, is the patient getting better or worse? And you know very well, 40% of strokes come from hypertension. If it's not getting better in a month, it's not going to get better at 2 and 3 and 4.
Mhm.
Change the dose, change the drug. There's a lot of things that we can do. What do we tell the patient? Come back in 4 months. And they come back and it's still elevated. What do we say? White coat syndrome. There's a reason why only 60% of people have adequately controlled high blood pressure, and even less than half of patients with diabetes. We just need to have a different approach. And this is generative AI.
Mhm.
How do they use this tool? How do they maybe do 30% of what doctors do today? Not having 30% fewer clinicians. Doctors are overwhelmed. But how do they do 30% of what we do so that we have the time that we need to
Mhm.
make sure we don't have a medical error, to make sure we focus on the patients whose problems are more complex or who are more resistant to the kinds of treatment we might have done in the past? This is the opportunity, and we've never had it in the
Mhm.
history of medicine.
Wow. Wow, you've really laid out the stakes there. This is really an important moment for a lot of physicians. And you've spoken additionally along these lines about prevention being undervalued in American healthcare. If you had a blank slate, how would you design incentives to finally make prevention a priority, like outside of AI even?
It's not that complex. If you are able to, I'll use the word capitate, pay a set fee, not to a single physician. You can't capitate at the individual doctor level. The variation is too great. But to a group of clinicians to take care of a population of patients. And they know that at the end of the day, they're going to get rewarded based upon how healthy they can keep people. You don't have to figure out the incentive system. They'll figure it out. They'll figure out the way to do monitoring. They'll figure out how to use generative AI. They'll figure out how to make sure that at every visit, every clinician is checking to see how well the patient's doing. I don't know about yourself. I couldn't even tell you the right drugs and dosages to manage hypertension, but I can identify it and I can connect with the primary care physician and I
Mhm.
can even say, what would you like me to do? Because they can tell me what's needed given that clinical history. And as I said, I think that a lot of this will get done technologically so
Mhm.
that rather than having to bring people back to the office all the time, we can do it through a text or an email or in some other way, very convenient, time efficient, be able to better monitor the chronic diseases, invest the time in prevention.
Mhm.
We can start to look at opportunities to be able to take patients, let's say, with heart failure and using wearable monitors, figure out 3 days before they're going to be in the ER that they're getting worse based upon their ability to climb stairs, the ability to lie flat in bed, all the things that we learn in medical school. How do we then figure out how to translate that so we have a warning?
Mhm.
Again, I don't know your practice, but most places that I've been, we're sending patients home from the hospital sicker than we used to admit them. That's just the nature of hospitals today.
Mhm.
And then what do? You're on your own. Your 90-year-old wife is now responsible for your medical care. No. How do we have monitors that are going to be able to tell us how the patient is doing? Not really tell us, monitor how they're doing. And then not when the complication happens, but when the problem gets worse, connect them with the physician in a telemedicine center overseeing a larger population of patients. What we confuse that if you have 100 patients who are in this, let's say, post-hospital situation, 90 of them are going to be doing well. We don't need to take care of them because the monitoring is happening. It's the 10 who are not. And what we say is we got to call 100 patients. So we never have enough time for the ones who need it. We spend a lot of the time on the patients who don't need it. And the results, as we may imagine, are not what we would want or expect.
Yes, yes. And actually, this is going to cause me to go off script for just one question, but I'm very intrigued. As I work on the wards, I see a lot of um, value-based care principles being incorporated into electronic health record systems. And you oversaw one of the largest deployments of electronic health records in America. How would you reply to the physicians who may be saying, this is just extra paperwork for us. There are all these quality incentives we have to do, and we have to write down, we gave this patient, X preventative measure, and they're like a general surgery team. And like, I've just heard from many physicians that sometimes these value-based models or even capitation-based models that lead to preventative steps being taken by administrators, incorporating that into records leads to additional administrative burdens, even including, ambient AI that listens to physician conversations, even including that, the physicians still have to then redo the notes, their inaccuracies. How would you respond to those queries? I'm very curious.
First, I'd say they're right. The way we do it today isn't reasonable. What do I mean by that? Well, if you give a capitated methodology of payment to an insurance company, how are they going to improve people's health? How are they going to improve disease management? They can't. So what do? They put in prior authorization and claims review and rejection. Why is that? It's the only thing they can do. They don't want to hurt people. That's just what happens. And
Mhm.
now all of a sudden you're spending a 30 a day on bureaucratic tasks and paperwork. Hospital administrators can't do preventive services. Sure, they may be able to fill out data to tell some payer. This is the fee-for-service methodology. It doesn't make any sense.
Mhm.
And capitating it at an insurance level or a hospital administrative level, that doesn't make sense either. Capitate it at the physician level, and now you eliminate that.
Wow.
It's interesting to me. I was on a podcast 2 days ago, and the person who was my host was talking about how challenging RVUs is in their particular environment and how they would get feedback on how many RVUs they would generate. And I said, amongst the 10 million physicians, none of them have RVUs. We didn't even know what an RVU stood for because it wasn't a measurement we used. What measurement did we use? Is the blood sugar being well controlled based on the hemoglobin A1C? Is the patient with heart failure being able to be kept out of the hospital? Did the patient with a surgical procedure develop a wound infection? Those are the measures, and we should be concerned about them and taking care of them. When you get lots of alerts on your electronic health record today, is this patient allergic to something? You already know the answer to that question. It's not improving clinical outcomes. Now, if you order a medication and there clearly is a problem, that's worth making certain that you were aware that they had the allergy in the first place. But almost everything that we have are the things that were easiest for the developer's electronic health record, not the things that are most vital and useful to the clinicians. That all changes as soon as you capitate at the delivery system level, at the clinician level. Because now you and I and 100 other doctors figure out what are we going to do?
Mhm.
How are we going to keep people healthy? How are we going to prevent disease? How do we want to spend the resources? Because ultimately, we're going to be measured on the quality of care and then to extent the cost of that care by being able to improve outcomes, not limit and make worse clinical practice.
So you're really exposing a very interesting rift between leadership and the people on the ground. And you've engaged with a lot of policymakers in Washington, including the bipartisan Congressional Task Force on Delivery System Reform. What do you think these politicians and policymakers most misunderstand then about how care is delivered on the ground?
They believe that the current healthcare system is the right structure because they don't know any different. That's the challenge that's there. Who do they talk to all day long? Lobbyists. What does the drug companies say? if we don't charge 5 times as much for the same drug in the United States as in Europe, then patients are going to die because no drugs are going to get created. Well, you look at the data, it's not true. You look at the data, maybe one drug wouldn't get developed, but look at the drugs that are being developed today. Are they working on new antibiotics because we're facing a cliff where we're going to have antibiotic resistance? No. Why? Because the profit margin isn't there.
Mhm.
Are the drugs that are being created highly effective? Not really. Occasionally, most of the time, they're not being developed by the seller of the drug, but by a different startup that's sitting somewhere in the community. We have a lot of opportunities that they don't understand because they have to be expert on everything. If you and I had to know everything about, manufacturing and about uh, space and about foreign policy, we wouldn't know as much about medicine. And that's what I think. And our voice has not gotten heard adequately. And when it has gotten heard, it's gotten drowned out by both campaign contributions and lobbying dollars.
From what I understand, and correct me if I'm wrong, I was listening to a Nejim podcast where they were discussing Mark Cuban's uh, cost plus pharmacy, and he was discussing, the rise of pharmacy benefit managers, and they were discussing how drug companies can often be a false target for politicians. That, the pharmacy benefit managers are the real um, uh, drivers of a lot of these changes in healthcare. I was wondering what your thoughts were with regard to that versus, pharmaceuticals and where physicians can play a role in lifting up their own voices amidst these giant large entities.
I think both are a problem, and each try to point the finger at the other to take the spotlight off themselves. Take a guess what the average cost of a new drug released last year was.
I I don't I mean probably maybe what per drug maybe seven figures. I wouldn't know. I mean, is this
The average sales price, these are the sales price of
sales
a
price?
medication per
Oh,
patient per year
I
to
mean, I
last year.
I would not be able to guess.
Just throw out a number, throw out a round number.
Uh, $400?
How about 300,000?
Wow.
The average new drug released last year. Now, do you think that's being developed because those are the drugs that are going to make the greatest advance in medicine? No, we can't spend that. And do you think the fact that we charge 5 times as much or pay 25 times as much for a GLP-1? We have a major obesity problem in the United States. 30% of Americans have diabetes or prediabetes.
Mhm.
And if it was priced at the same level as most European nations, around $200 a month, we could afford. It would actually be cost effective compared to the expense of treating the heart attacks and treating the cancers and other things that come out of the obesity crisis. Instead, we have a starting price of over $1,000 a month, and maybe a negotiated price that's down near, $500 or $600. That's 3 to 5 times higher than other countries.
Mhm.
It's really not justifiable. And yet, what happens? Congress passes, to the point you made earlier, legislation extending the patents. We
Mhm.
tolerate what drug companies do when they bring lots of more patents. So you can't quite effectively battle them unless you're a Mark Cuban. So
Mhm.
no, I think the drug companies are problematic, but so, as you say, are the intermediaries. More so in the past because they've been exposed a little bit right now. But essentially, drug companies give rebates when they prescribe more expensive medications. So they prescribe more medications and they keep the rebates and they'll give them to patients. I mean, again, try to think about a more broken system. I teach, as you say, in the medical school and the business school. And the business school, and I try telling the business students the kinds of things that drug companies do, they think I'm lying.
Mhm.
This is exactly what is happening right now. What we've seen is two things: monopolization, by which I mean drive the price up through some type of protection. Hospitals consolidate to accomplish that, drug companies have patents to accomplish that. And the second thing is shrinkflation,
Mhm.
provide less for the same price. and then across time basically generate more profit. That is what is driving medicine today. And again, not at the doctor level. We're talking right now at the insurance company, at the hospital level, at the drug company, and that is what has to change. And I don't see any way it's going to change until we're able to move the dollars to the clinicians directly with risk, and they're embracing a generative AI tool to be able to keep patients healthier and empower them to take care of the things that they can do. And then we have to take care of the things that they can't. You know, I'm sure you've heard it many times. We want everyone to practice at the top of their license.
Hmm.
Well, I think what we need to do is have the patient practicing at the top of their expertise that they garner through generative AI technology.
Oh, interesting. So kind of the patient develops expertise in the condition themselves and then improves health literacy. Interesting. Yes, yes.
And uses generative AI to accomplish that. And to do that, they have to understand how to use the tools, which means you basically need to know how to prompt the large language models. That's why I never use the word AI. I use generative AI versus the older, I'll call it narrow AI. But the generative AI tools, as long as they know how to prompt it, follow up on it, and limit it, I would say, to those kinds of routine problems, upper respiratory infection. I mean, we know as clinicians almost always this is not going to be something serious. And very quickly, we could ask a few questions to discern whether it might be based upon the level of the temperature, maybe on the color of the sputum, a couple of other points that are sitting there. And yet we spend a lot of our time taking care of problems for which the answers are very algorithmic, very straightforward. The same thing for basic infections that sit in place. You know, the technology, and I want to add the fact that generative AI technology is not just words, it's also, sorry, not just typed words, it's also verbal words, and it's also images. You know, I'm a surgeon. I do a procedure. What do I tell the patient? If you have a wound infection, give me a call. Or if it turns red and painful, give me a call. Well, the patient isn't trained. You know, our residents take a while to figure out how to discern those pieces. Have a generative AI tool examine that wound every day, and then let me know if there's a concern. And I can look at the images and decide in a matter of seconds. Because if I can find one patient out of 10 or see 10 patients in order to find one patient who has an infection and treat it today with antibiotics rather than 3 days from now with hospitalization and a procedure, I've just not only achieved far better outcomes, but I've also saved costs.
Mhm. Absolutely. Yes. And really all of this discussion about saving costs and the combination of that with the generative artificial intelligence ties right back into your book, ChatGPT MD, this new series that is all profits going to Doctors Without Borders. I am very curious, how do you see the role of ChatGPT specifically on um, enhancing the physician workflow? How do you see it specifically incorporating into how physicians communicate with patients and do their day to day, specifically for surgeons too? A lot said about clinicians, but surgeons.
First of all, I use ChatGPT just because I wanted to write the book that would be
Yes.
GPTMD. So it just flowed smoothly. But Claude and Gemini are essentially the same.
Hmm.
So when we use that, it's just like saying Kleenex or something. It's just a name for a brand more than it is for a specific company's products. And I have no financial attachments to any of these companies. In fact, I have no financial attachments at all. I have no advertisers on my podcast. And just so listeners are aware of that, just like it was a medical conference, you have to acknowledge any conflicts of interest, of which I don't have any. And Doctors Without Borders, as you will know, is a not-for-profit. So we're in good shape around all of that. But I'll give you a couple of examples. I was talking to a surgeon a little while ago. She did a very complex neck surgery. She knew it had gone perfectly.
Hmm.
And yet at the end of the operation, the anesthesiologist said, I can't extubate your patient. The vocal cords are adducted for non-clinicians, stuck together in the middle. If I take the tube out, there'll be an obstruction. Should I bring the patient to the ICU? She said, hold on a second. Went to ChatGPT, asked about it. Immediately, there were 4 cases. of exactly the same thing. Because what had happened, as you well know, when we do this kind of procedures, we inject a local anesthetic that has adrenaline. And why do we do that? Because we want the vasoconstrictive effect. And for whatever reason, in some people, these cases, it diffuses out of the area for
Mhm.
whatever reason to, in this case, the nerves that go to the larynx. All the cases, of course, as soon as the anesthetic stopped working, the cord separated. And she said, no, let's wait a little while. 30 minutes later, the cord separated. The patient went home. It went fine. I was
Wow.
talking last weekend to a surgeon, and he had done a microtia repair. And when you do a microtia repair for a child born with a major deformity of the ear, you often take ribs out. And when you take ribs out, you run the risk that you will have damaged the underlying pleura. So got a chest X-ray, and just decided for fun to show it to ChatGPT, and it created a radiologic report that was almost identical with the radiologist would put out 12 hours later. Now, fortunately, in this case, there was no big problem that needs to be addressed. But had there been a pneumothorax that had been missed as a result of the surgeons, for whatever reason, not quite seeing it the way they should have, maybe it was so great it didn't look that way,
Mhm.
we would have had an answer and prevented a complication 12 hours earlier. Those are just two examples of literally hundreds that I receive all the time. I think once we start using this tool, that's my big push these days, by the way.
Mhm.
I want every clinician to just start using it, try it. Now, your residents are already doing that. That's how they prepare all of the grand rounds and all the other material that they use. But for all of the surgeons, put the information in from the patient and then see how it compares to what you told them. And if the patient, have them put the information into their system as they would have told it to a doctor and see how that compares to what the clinician said. It's interesting. I was in a podcast last year. A woman said to me, Dr. Pearl, I know you're a big skier and you're a doctor. My husband fell 3 months ago. His arm was over his head. He slid about 100 feet down the mountain. 3 months later, his shoulder still hurts. He can't use that arm like the other side. What's going on? And I said, you told me on the podcast today you'd never used your generative AI tool. You had one, but you never used it for medical questions. Put the information in place. Let me know what it says, and then I'll tell you what you should do. 5 days later, she calls back and says, thank you. I put the information in place, and it said he probably has a rotator cuff tear. He needs to have an MRI to establish the exact diagnosis, and you should consult an orthopedic surgeon specifically because you almost definitely need surgery to repair it.
Mhm.
Now think about that compared to Google Doctor. You
Mhm.
know, you get a million links for shoulder pain, another million links for inability to use one arm like the other side. When she went to see the clinician, and he said, you probably have a rotator cuff tear. She knew exactly what the rotator cuff was.
Mhm.
And when it said he needed an MRI, she didn't question it. She knows exactly why he was getting the MRI. And at the end of surgery, the physician said, had you waited 3 more months, I probably could not have gotten the tendon back to the bone.
Wow.
Now, think about
Wow.
how different that is than the way that we practice today. And by the way, you can do that in every language for all the different patients you take care of in Washington, D.C., who come from a variety of backgrounds. We are just scraping the surface of this technology for its applications in medicine. And I think it's going to have more power inside medicine than in any other field. And why do I think that? The limiting factor with generative AI is the data upon which to train it.
Mhm.
Now, when you make your rounds in the mornings, I'm sure you did today, all the monitors are beeping. It generates a terabyte of information, 10 with 14 zeros. 97% of that we pay no attention to and throw it away. Imagine if we could figure out what's going on. Research that might have taken years, we can do in a matter of months. And now think about the nurses who are on the floor taking care of your patients today. What do? They round at 8 o'clock, they come back at noon. Imagine if they knew how every patient was doing and who was in trouble. The equivalent of having a telenurse, but better than that, who can do every monitor. We are just scratching the surface, and I just can't encourage all your viewers and your listeners enough. This is the time to experiment, even if you're not going to use it. Experiment with it, learn about it, figure it out, and I will guarantee you, even among your users, will have dozens of ways that it could apply, both of the providers of care and its recipients.
That's incredible. I mean, 30 business ideas just came out of that. Just speaking about that. So, no, that's fantastic. And really, bringing this back to our listeners because this is really, what this video podcast series is all about. Um, what advice, or if you were speaking to a medical student or resident today, what what advice would you give them to thrive in this healthcare system that will look very, very different by mid-century?
Well, you're really asking two questions. My advice to them is don't give up. The system is impossible. The training is grueling. Do the best that you can to survive, and it's not what it's going to be like 10 years from now when you practice. Now, I'd also give them the advice to get ready to be practicing in 10 years because the way you're being trained today most likely is not the way that you're going to work in the future. And what I am encouraging deans to do is to change the curriculum so that we teach them not how to use generative AI. They all know how to use generative AI, but they don't know medicine. So, how do we apply this in these kinds of ways? And I'd be asking them to think about it, to figure out how this can radically improve healthcare with the goal of reducing either postoperative infections or reducing the implications of that because we diagnose it too late rather than early enough. How can you improve diagnoses? How can you improve patient adherence? How can this become a new powerful tool
Mhm.
to both educate patients and to empower them? Uh, so I wish I could tell them this is going to be the most important class you take because you will figure these things out and learn about them. They're not going to get the class. So
Mhm.
I'm telling them struggle through what you're going to get, but also be thinking about how you're going to apply it in the future.
And maybe take some of your classes at the business school as well.
That's possible. Yeah, yeah,
Yes,
yeah, yeah.
yes.
And it may be different in your academic center than all the other ones I visited, but I'd be surprised. I'm sure somewhere there's a lecture that they mention it, and maybe they try to tell people how to use it. But I can guarantee you they don't spend the time and invest the time to ask how would it achieve better outcomes than today? How can we transfer sort of like the ATM. How can we transfer 30% of what we do to the patient in a reliable, safe way so that we have the more time that we need? And I would even hope that in doing so, we could reduce the burnout. Because I think at the end of the day, doctors often go home frustrated, unfulfilled. They haven't done as well as they could do, not because they didn't know what to do. They just ran out of time.
Mhm.
And they did the best they could with what they had. If 30% of the work were to go away, then we could invest the time needed in the remaining 70% and do an even better job, more fulfilling job than currently.
Yes, yes. No, absolutely. And I really, actually, when you say reinvest that time, there is a strand of people who sometimes say, the profit incentives, a lot of things are going to press clinicians to just do more with the same amount of time. And so I just briefly wanted to hear your thoughts on that as well.
You're
Because
absolutely right.
productivity is
But
not
that's
going
why I
to,
double back. That's why I double back to moving from pay for volume to capitation. The two
right.
these things go together. You either, it's interesting. The founder of Kaiser Permanente, Dr. Sidney Garfield, by now probably 80 years ago, he said, we don't need a sick care system, which is what we have today. We need a healthcare system.
Mhm.
And we do not have a healthcare system. And if we had a healthcare system, now we would be thinking about how do we use these tools in the most positive ways. And today we'll just try to figure out how do we use these tools to generate money. And it's just going to generate more and more and more work because someone else will take the leadership, they'll take the control. And increasingly, as you well know now, 70% of clinicians work for some other entity, whether it's a hospital, an insurance company, or a private equity firm. And unfortunately, we're becoming workers. We're not becoming professional leaders.
How,
And
how
that's where I believe that we need to go.
how do they break the cycle? Like, what can an individual physician do?
I don't think that an individual physician can do anything. I think a group of physicians can. And what they can do is to create an alternative. And so when the insurance company comes around every year to negotiate all the rates that it often does, usually just imposing them, by the way, now we're going to say, no, we're 80 doctors and we're not going to participate unless we're paid in a different kind of way. It's not a question of how do we get paid, 7 cents more when we do this and 9 cents more when we do something else. How do we have both adequate income and control? Because the linking point between those two is the health of the patients. If we could avoid complications, if we could avoid the diseases in the first place, if we can figure out the right patients for the right procedure and do it in the right way at the right time, I think we could take out what I will call 30% of waste. And I want to be very clear. People are working very hard during the waste. They're driving all the time. They're up at night. It's not their fault. It's
Mhm.
that the system rewards that rather than what it should be doing, which is rewarding the fact that we've kept people healthy and therefore we have more time. That's our time to invest in our lives and our families and the other ways they're going to go. This is not about doing more. Doing more is a losing proposition. This is about doing better. This is about the opportunity to be able to get things right the first time. And we could spend an entire semester talking about all the different ways that it could happen. How do you structure to maximize clinical outcomes and quality? But we don't have time in your podcast today.
Yes, I appreciate it. Thank you very much. This has been an incredible conversation. Thank you so much for joining. This will be very valuable for our listeners. And please feel free to read Dr. Robert Pearl's book, ChatGPT MD, out now worldwide. Thank you very much.
Yeah, and my website's robertpearlmd.com. Feel free to go there. And as you discover things, as you learn things, as you find ways to apply generative AI, as you find ways to keep your patients healthier and safer, please let me know so I can spread the news across the nation and around the world. Thank you for having me today.
Thank you so much for joining us on Cutting to the Case today. This is Cameron Sabat signing off.